Hello, everyone. My name is Melanie Vargas, and I'm a second-year medical student from the University of Florida. Is it this?
Yes, the green button on top.
Okay.
No, yeah.
Perfect. Okay. And these are our disclosures.
Couldn't do that.
So perioperative hyperglycemia has been associated with adverse events and worse post-surgical outcomes. The Journal of American College of Surgeons published a study in 2015 looking at 438 major abdominal operations, and their results showed that a hemoglobin A1C that was greater or equal to 6.5% and hyperglycemia led to adverse events. An expert panel consensus was made in a paper published in 2015 that recommended deferring elective ventral hernia repair in patients that had a hemoglobin A1C greater than or equal to 8, but data specific to ventral hernia repair was lacking. Okay. There are established guidelines for surgical site infection prevention. The American College of Surgeons basically stated that diabetes, diabetic medications, and hyperglycemia are all risk factors, but there was no evidence that proved that improving hemoglobin A1C decreased surgical site infections. The CDC also suggested a glucose target less than 200, but there was no recommendation for hemoglobin A1C. So our objectives of our study was to assess the association between hemoglobin A1C and postoperative complications following ventral hernia repair in diabetic patients. So we conducted a retrospective cohort study from 2012, using data from 2012 to 2021, using the ACHQC. We included adult diabetic patients undergoing elective ventral hernia repair with an hemoglobin A1C available, and we excluded any patients on immunosuppressants, have current mesh infection, enterocutaneous fistula, and with no 30-day follow-up. Okay, so we looked at hemoglobin A1C first as using what the expert panel suggested as a cutoff of 8%, and then we looked at it as a continuous variable. We did a multivariable regression, and then we looked at composite recurrence using a Kaplan-Meier and also a Cox proportional hazard regression. So our results showed that there was no clinically significant difference between the two groups in terms of age, gender, BMI, or ASA. The median hemoglobin A1C was 6.5 in the first group, 8.7 in the second group, and there were more smokers within 1 year in the group with a hemoglobin A1C more equal to 8. There was also no difference in hernia width, proportion for recurrent hernias, and hernia type. About 1/3 of the hernias were recurrent and 3/4 were incisional. Okay. So the most common wound class was clean. 2/3 of the hernia repairs were performed open. Mesh was used in 91%, and the most common mesh type was permanent synthetic. Half of the mesh was placed retromuscular, 1/3 preperitoneal, and 1/4 intraperitoneal. Myofascial release was performed in 50%, and drains were used in half of the cases, and concomitant procedure was performed in 1/5. There was no statistically significant difference in the operative details between the two groups, except operative time, more than 2 hours, and drain use. Okay, so the median follow-up was 27 days, which we do recognize is fairly short. 1/4 of patients developed a complication, and there was no statistically significant difference in the adjusted outcomes between the two groups, including overall complications and wound complications, except readmission rate. However, the difference in readmission rate was clinically insignificant. Baseline Hercules quality of life score was similar. The 30-day score was statistically higher in the A1C less than 8 group, but difference was clinically insignificant. There was no difference in the baseline or 30-day promise pain scores in both groups. Our Kaplan-Meier curve showed no difference in composite recurrence-free probability between the two groups up to 24 months. This graph plots the odds of complications against the spectrum of hemoglobin A1C using hemoglobin A1C of 7% as a reference. The blue line represents the odds ratio of complications, and the gray shaded area represents the confidence interval. Because the confidence interval crosses 1 at all points, this graph shows a lack of association between hemoglobin A1C and complications. This is also a similar graph, but it's showing a lack of association between SSI and hemoglobin A1C. And this graph shows a lack of association between composite recurrence and hemoglobin A1C values. So to conclude, our study found that in diabetic patients undergoing elective ventral hernia repair, hemoglobin A1C is a poor predictor of overall complications, surgical site infection, and composite recurrence. Our findings do not support deferring elective ventral hernia repair in order to lower hemoglobin A1C. Thank you.